Hello, my name is Dr. Naomi Dambreville. I am a licensed adult and child clinical psychologist and assistant professor of psychiatry at the Mount Sinai Hospital and Icahn School of Medicine in New York City. To ask about them and to understand that they exist, and to do our best to tackle them. I think as an individual provider, psychiatrist, psychologist, mental health provider, there are limitations on what we are able to do for any one patient. But luckily, right, when you work within a clinic or a system, thankfully, for example, at Mount Sinai, using the resources that are embedded in the system. So, referring patients to care coordination, referring them to community resources, making those referrals, helping them see that they're here. A lot of people, you might offer a resource that they didn't even know existed, right? Something like, oh, we have people who really can help you navigate like the school system. We have, people who oh yeah, did you know you can just call up the hospital financial department if you're having some issues? Like some people just don't know what questions to ask. And at the same time, there's only so much that any one provider or even a hospital or medical system is able to do to tackle all the systemic, you know, inequities and disparities that exist in the world, but that impact our patients' lives. What we can do is to be mindful, is to remain vigilant and educated and practice personalized medicine at all times, meaning that like, right, not everyone, the DSM um is our sort of like guideline, but patients are not just a list of symptoms and rates. It's to also expand maybe the care team. So not just other providers, but I fundamentally believe that health mental health care does not exist only in like the clinic or the patient room. I think it really exists in communities. And so I think concrete steps that we can take on a larger scale is to really be engaged in community like work or collaborative care with community practitioners, with community systems, like a lot of these conversations around mental health, even if that's not the word, the terms that we're using, happens in the local, churches and hair salons and schools and parks. And that when and those people are often looking for help or looking for something they might not know what they need, but then to sort of try to increase like mental health literacy in the world so that way anyone can say, hey, I think that sounds like something you can talk to someone about because they can help you with that, right? You don't necessarily need to have a diagnosis to do that. So I think just really being community engaged, really thinking about how to bring the work that we do into the community and also definitely not relying on people to walk into our office on their own all the time. Sometimes we do have to go to them. One, just like acknowledge that we all hold like inherent, bias and prejudice and judgments, and that even as clinicians, like the work is to really self-reflect and do our best to not perpetuate those harms as clinicians. So sort of not just to do well or to do good, but to not do harm. I think that's probably like one action. So being mindful of hey, is there something happening here that I'm not acknowledging? Am I feeling nervous or worried about, am I so cautious about maybe not offending someone that I'm not asking the important question, that I'm not learning how to apologize, or I'm not learning how to, right, kind of sit in difficult moments. To be able to sort of create more of an opportunity for people to build that trust that people need um, to want to be seen and heard and to allow themselves to be seen and heard. Things that kind of come up in this conversation, I think, oftentimes these conversations are happening in training environments. So where, the idea of like cultural competency, cultural humility, those kinds of concepts. And a lot that often kind of coincides with what does our workforce look like? And so I think making sort of it feels important to acknowledge that yes, we do need the systems and different systems to support building a more diverse workforce, especially behavioral health workforce. Um, and we can't do that without acknowledging all these other structural structural barriers and difficulties, but also that you can have a diversity in workforce and it will be ineffective in providing, competent care if they're not culturally competent, if they're not, practicing in a diversity informed, open manner, or if they are doing their best to do so, but the system itself is not culturally responsive, right? So I think really kind of thinking about those pieces and how it's one not easy to just increase the workforce, but it's also not easy to change a system, but the work kind of has to be done.